My name is Alexis Ogdie. I'm Associate Professor of Medicine and Epidemiology at the University of Pennsylvania. And today I'm going to be talking to you about the epidemiology of psoriasis and psoriatic arthritis. These are my disclosures. So when I think about the epidemiology of a disease, I think about how common is it, so the prevalence and the incidence. In addition, what leads to the disease, so risk factors for disease, and then associations with disease, so comorbidities in this particular case. So I'm going to cover these three different topics today within psoriasis and psoriatic arthritis. Now, there are three main takeaways I want you to take away from this lecture. Number one is that psoriasis is really common, and we probably miss it. Most patients have mild psoriasis, and it tends to hide in certain places like the scalp and the belly button and the gluteal folds. And this is particularly important for our patients who have undifferentiated inflammatory arthritis. Number two, there are risk factors for psoriatic arthritis. These may be modifiable in the future. There's a lot of kind of future work going on there. For now, it's helpful just to understand what they are, and patients tend to feel better when they kind of understand what may lead to the disease. And then next, comorbidities are what put our patients at most risk for death and other bad outcomes, such as myocardial infarction, decreased function, and also diminished health-related quality of life. So let's start with the epidemiology of psoriasis. The prevalence of psoriasis in the Western world is somewhere between 1.5 and 3%. Estimates in the US seem like they're in the 2 to 3% range. Now, this disease mainly affects adults. It's not that common in children, only about a prevalence of 0.13% among children in the US. However, if you think about this disease being a very prevalent disease, it affects over 125 million patients worldwide, so it's pretty common. Males and females tend to be equally affected. This is also true in psoriatic arthritis, equal male-female predilection. And finally, the age of onset. So in psoriasis in particular, there tends to be a bimodal presentation. And this presentation tends to be in the 18 to 40 range or in the later 50 to 70 range. So it's kind of that earlier group and the later group. When we talk about psoriasis, we typically have in our mind the idea of plaque psoriasis. So those kind of raised scaly plaques. But in addition, there are several other types of psoriasis, including guttate psoriasis. That's small kind of pinpoint lesions all over the body or in large distributions that tend to be following a strep infection. That's one example. Pustular psoriasis, it tends to affect the hands and feet. And then erythrodermal psoriasis, which can kind of look like a burn or erythema all over the body. Those patients tend to need to be, are frequently need to be hospitalized, or at least that is a risk. So this is an example of plaque psoriasis showing the kind of key features of psoriasis on the scalp. So there's erythemas and erythematous base. Induration, if you rub your hand or finger over that, that would feel raised. And then the scales, so those silvery scales that we think about. Here's an example of psoriasis in the ear as well. Psoriasis also affects the nails, and the nails are commonly affected both in psoriasis and psoriatic arthritis. About 50 to 80% of patients have nail disease as well. And the classic features are these pitting lesions. So it literally looks like you take a pin and you push into the nail, as well as onycholysis, where you kind of see this lifting away of the nail from the nail bed. Ridges are not necessarily a psoriasis phenomenon. The nail pitting and the onycholysis are the most specific, although there are a variety of other nail features as well. All right, so let's move from psoriasis into psoriatic arthritis. Psoriatic arthritis happens to be the most common comorbidity among patients with psoriasis. The prevalence in the general population of psoriatic arthritis, so across all patients, not just psoriasis, is somewhere around 0.1 to 1%, depending on the population that you're studying, and particularly around 0.25% in the United States. Now, the prevalence of psoriatic arthritis among patients with psoriasis is obviously higher, so somewhere around 20 to 30% is often what we quote. A recent systematic review by Ali Nahi found that it was around 20%. The incidence of psoriatic arthritis, so the number of new cases among patients with psoriasis who haven't had a diagnosis of psoriatic arthritis at baseline, varies from 0.27 to 2.7 per 100 patient years. So that means over the course of 1 year, for 100 patients, about 1 to 2 will develop a new diagnosis of psoriatic arthritis. What's interesting, though, is that these estimates are based on diagnosed disease. And what we know from some studies is that about 15% of patients with psoriasis have undiagnosed psoriatic arthritis, so it hasn't yet been recognized or officially diagnosed. That's from Villani et al. They had a nice systematic review about this. So when we talk about the prevalence of psoriatic arthritis in psoriasis, we kind of think about the whole group, which makes sense. But if you want to look at the subgroups of patients with psoriasis based on the severity of the disease, if you break them into mild, moderate, or severe psoriasis, where mild is less than 3% body surface area is 1% of the palm. The patient's palm represents 1% of body surface area. So 0 to 3 palms is mild, 3 to 10 palms is moderate, and then more than 10 palms is severe. So about 30% of patients have moderate, about 12% of patients have severe, so then more than half have mild. But then if you look at the prevalence of psoriatic arthritis in those three groups, there's clearly a difference. So among patients with mild disease, it's only around 5%. With moderate, it's around 10%. And then among patients with severe psoriasis, it's around 30%. The incidence actually looks quite similar in that there is a stepwise increase in incidence of psoriatic arthritis by severity of psoriasis as well. Now, you may say, well, of course, most of my patients in clinical practice have mild psoriasis. Yes, that is true. So the vast majority of patients with psoriasis have mild disease. So it also makes sense. The majority of patients with psoriatic arthritis have mild psoriasis as well. It's just that when you break them into these groups, you see a difference in prevalence and a difference in incidence. So speaking of incidence, among patients with this risk factor, severe psoriasis, what are some other risk factors for this disease? We recently reviewed this in a Nature Reviews rheumatology paper published in 2019. And the dark blue are things that are found to be risk factors for disease. And you can see the number of studies is kind of shown by the width of the bar. So you can see that obesity is a very commonly studied risk factor, and it seems to be repeated in multiple different studies. So clear risk factor there. Having symptoms for the disease like stiffness, joint pain, or fatigue was associated with having an eventual diagnosis for psoriatic arthritis. And then a couple studies of psoriasis severity as well. Smoking and psoriasis duration, not quite so easily related. Not quite sure about that, not linear relationships for sure. And then nail disease is a risk factor for psoriatic arthritis. That might be that there's an enthesis right below the nail there. And finally, trauma. So trauma is an interesting one. We kind of think about stress being a risk factor for psoriasis. So many people have psoriasis come out after a very stressful event, whether that be physically stressful or emotionally or mentally stressful. And it seems that this is probably also true for psoriatic arthritis. So specifically, there's been a study on trauma, like joint trauma or bone trauma, and those were associated with development of psoriatic arthritis as well, among patients with psoriasis and among the general population. So we think that some patients with psoriasis may have some of these different kind of underlying risk factors, whether that's obesity, medical comorbidities, some underlying inflammation, or genetic risk factors, some of which we don't fully understand yet. And then there's some second hit or trauma, for example, new comorbidities, some stress of some sort that kind of really triggers the disease. And it may be that there's this continuum from having skin disease to having preclinical disease, then subclinical disease where you can see it on an ultrasound, for example, but it's not yet clinically overt. Then prodromal where patients have symptoms, but we don't yet see it on exam. And then they have overt PSA. Now, I bring this up because it's kind of important that we recognize this prodromal phase. We don't know what exactly to call that. A lot of patients are diagnosed with fibromyalgia in that point in time because you can't yet see anything on exam. If you have a patient with psoriasis and fibro, that's someone I do follow over time just to see if something else comes up. Because within 3 to 5 years, sometimes some new inflammatory arthritis may come up. All right, so then what are some potentially actionable risk factors? So these are some things that we've been discussing in the literature, but also in trying to address in different studies. One is the psoriasis itself. You wonder if you treat psoriasis with biologic agents, for example, or even phototherapy, maybe there is some modifiable effect on development of psoriatic arthritis such that we kind of remove this potential trigger time. Obesity, we do know, is a major risk factor. And there is one study that has suggested that if you lose weight, you can actually improve the likelihood of developing psoriatic arthritis. And finally, depression. So this is an interesting one. Depression has come up as a risk factor for psoriatic arthritis and also potentially a risk factor for psoriasis. It may be a form of stress. So maybe reducing stress or reducing depression, for example, could improve outcomes. So lots of different studies to better understand what's going on here. I won't go into this in too much detail, but I think this is kind of a space to watch in terms of how we might think about better understanding this. This is that reference that I mentioned about if you modify weight, if you decreased your weight among those who are obese, you actually decreased your risk for developing psoriatic arthritis. If you gained weight, you actually increased your risk for developing psoriatic arthritis. So kind of interesting when you're counseling patients with psoriasis about weight loss. Okay, speaking of obesity, this is one of our many comorbidities in psoriatic arthritis, in psoriatic disease. So I put PSD here. So for both psoriasis and psoriatic arthritis, they share many of the same comorbidities. So first, there's extra-articular manifestations like uveitis and inflammatory bowel disease. Now, those are kind of part and parcel of the disease and maybe genetically related. So I'm not going to talk too much about those, except for that they are important to ask about in your review of systems. Cardiovascular outcomes are important for considering management of psoriasis and psoriatic arthritis. So I will screen for lipids, for example. I will do the Framingham risk score, or you can use the more updated risk score from American Academy of, ACA, AHA, American Heart Association. And then metabolic syndrome and metabolic disease more broadly. So there's an increased risk for increased prevalence of metabolic syndrome and an increased risk for metabolic diseases in patients with psoriatic arthritis. We're going to talk more about that. Mental health, depression, anxiety are very common in psoriasis and psoriatic arthritis. So we're going to talk more about that. And then specifically for psoriatic arthritis, fibromyalgia is quite common. So we'll come back to that in a minute. So let's start with depression and anxiety. They're common in both psoriasis and psoriatic arthritis, slightly more common in patients with psoriatic arthritis. The prevalence of having depression or anxiety or both is around 36% in one particular study from the Toronto group. So quite high, and that was before the pandemic. So I'm sure that many of you are recognizing more and more depression and anxiety among our patients. So this is really important. First of all, depression and anxiety are a form of stress, so they can perpetuate the disease. Additionally, patients with depression and anxiety are less likely to respond to therapy, so it's important to address this as well. Finally, there is an increased risk for suicide among patients with psoriatic arthritis as well. The age and sex adjusted hazard ratio is around 3 compared to the general population. Even for rheumatoid arthritis, it's around 2.5. So how do we approach mental health in practice? So there's a variety of different ways. The first is just to ask straight up about anxiety and depression. You can do that as a part of your review systems. You can inform patients about the association. That's really important just to normalize that. Can revert patients for further assessment and management to primary care, and treating the disease often does help the depression and anxiety. You can use screening tools. So for example, in the review systems, or more formalized screening tools like the PHQ-2, which is just asking about over the last 2 weeks, have you had any little interest in doing things, feeling down, depressed, or hopeless? So it's a natural extension from talking about depression and anxiety as key components of psoriatic arthritis that fibromyalgia is also common. It's been found to be prevalent in about 20 to 30% of patients with psoriatic arthritis. This is also very important because if you're treating a patient with both psoriatic arthritis and fibromyalgia, you may find that these patients are not responding to therapy, or they're cycling through therapies. And it may be because the patient is having continued pain, but not active inflammation. So it's important to help patients figure out what the difference is between the two symptoms and what the therapy is likely to cover. I often draw this diagram out that talks about sleep, fatigue, biomechanics, meaning like your physical activity, exercise, physical therapy, pain, and stress, and how these things are all related, and we have to address all of them in order to kind of improve the pain. So only one part of this is actually the disease, treating the psoriatic arthritis, but treating the fibromyalgia is also very important. All right, next onto the cardiovascular comorbidities. So myocardial infarction is significantly increased in both psoriatic arthritis and psoriasis. In fact, mostly in patients with more moderate to severe psoriasis, as opposed to less severe psoriasis. Patients with mild disease probably don't have a significant increase in cardiovascular disease. So it's important to monitor for cardiovascular disease, as I already mentioned, by screening for lipids, for example. Also important to recognize that diabetes is more common in our patients. The hazard ratio for diabetes is around 1.4. So you can see in these particular studies that diabetes is even more common, or the incidence is even higher in psoriatic arthritis, the center bar there, compared to rheumatoid arthritis or controls at any given age. So when you're looking at the labs coming back, the glucose being high is really important to recognize. Obesity and psoriatic arthritis, we've already talked about that being very common, also problematic in that patients who are obese are less likely to respond to therapy. So weight reduction is really important. In fact, among patients who are starting a new TNF inhibitor, who are assigned to a freely managed diet versus a Mediterranean diet, it didn't end up really mattering how you managed your calories too much, although the Mediterranean diet was slightly better. It mattered more whether you lost weight. So among those patients, if they lost 5 to 10% of their body weight compared to less than 5% of their body weight, the odds of them achieving minimal disease activity was 3.75. If they lost more than 10% of their body weight, the odds of achieving minimal disease activity was 6.67. So substantial benefit from weight loss. So we should be encouraging all of our obese patients to lose weight. Obviously very hard. One of the things that we're working on in some of our studies, Leahy Eater and I, are to develop programs that you could refer your patients to so that it can help them with diet and weight loss. Because right now, this is very difficult to get patients to lose weight. Finally, when we're thinking about mortality in psoriatic arthritis, we talk about a whole bunch of different comorbidities. So are these comorbidities increasing mortality? Well, probably individually, yes. So if they have cardiovascular disease, they may be more increased risk for mortality. Same with diabetes, for example. However, as a broad spectrum across the general population, it's less clear. So there's some studies suggesting that there is an increased risk for mortality among patients with psoriatic arthritis. It seems that there is a clearer increased risk for mortality among patients with severe psoriasis. However, there are also studies suggesting that there's not much of an increased risk at all in mortality, and that's particularly true in the most recent time points. If you look in the distant past, there probably was a significant increased risk. Additionally, the types of patients being studied and the severity of the disease is also relevant for whether or not they're at increased risk for mortality. So if you looked in the Toronto cohort, which was a kind of a disease-specific cohort, particularly back in 2007, they published studies suggesting that there was a significant increased risk for mortality, and that was actually different by the severity of a patient's disease. So this argues for getting patients to lower disease severity, but encouraging patients that on average, most patients don't have a significant increased risk for mortality. All right, so let's go through some of those key takeaways again. First, psoriasis is very common in the United States, around 2 to 3% of the US adult population. So it's important to be able to recognize this among our patients and to look for it, particularly in those patients with undifferentiated inflammatory arthritis and joint pain. Number 2, risk factors can better help us understand the disease, but there's still a lot to be learned. I think this is a really exciting space to watch in the next few years. And finally, comorbidities are really important to improving outcomes for our patients. Not only do they affect treatment outcomes, but they also should be identified, and that's part of our job. So we should be screening for depression and anxiety. We should also be screening for cardiovascular disease and keeping an eye out for that blood sugar, for example. Additionally, we should be referring them to be managed and educating patients about the association between psoriasis, psoriatic arthritis, and these important comorbidities. All right, thank you so much for your attention.